वैसे भी मैं बहुत हेलो। सर, ऑडियो नहीं है इसमें। नहीं, ऑडियो नहीं है। दिल गाना इतना फ्रिक्वेंटली हो रहा है। हेलो। इतना फ्रिक्वेंटली हो रहा है ना कि फिर सीरियसली लेना नहीं। ये कैसे ऐसे? ये तो नेक्स्ट स्लाइड दिखा दो। ये नेक्स्ट स्लाइड दिखा रहा है। अच्छा, आजकल ऐसे ही तो लोग पर फुल ये आ रहा था, पर इसमें तो दिखेगा नहीं। हाँ, दिख तो रहा है। Good morning, sir. Should I start, sir? So this is clinical grand round for the Department of HPV and LT surgery. Uh, First, we are going to present the activities on liver transplantation for acute liver failure in the department, followed by literature, and followed by the technical aspect and video presentation. Coming to the donor characteristic, we will start with the donor. The median age of the donor is 21. Total number of liver transplantation for acute liver failure, including both pediatric and adult, is 133 patients. And donor age, the median age is 28 with a range of 21 to 49, that is interquartile range. And majority of the donors are female. Majority of them are first degree relative, which is 76%, and DDLT accounts for 3%, that is 4 patients has been transplanted with diseased donor liver transplantation. The type of graft for both adult and pediatric, which we are going to see in both adult and pediatric separately also later on. The right lobe without MHV is 48%, and left lobe graft is 33%, and left lateral lobe is 15%. And deceased donor, 3% of the patients. This is the donor characteristic, that is liver attenuation index. BMI is 24.3, and cumulative blood loss per case is 440 ml. Peak post-operative bilirubin is 2.83, INR 1.8. Hospital stays on an average 7 days, and follow-up of these donors are till 36 months. And the most important thing is evaluation time. When the donor first came to us for evaluation is 14 hours. Within 14 hours, all the 3 steps of the donor evaluation was completed. And depending upon the patient clinical status and indication, the timing, then transplantation happened. Clevin-Dindot classification for the donors, more than grade 3B complications. None of the donors had more than grade 3B complications. Coming to the recipient characteristics, the pediatric transplant happened for acute liver failure 73%. This data is till 2025 December, and adult patients 60 patients. Median age for the pediatric patient is 9 years. Adult 33 year with interquartile range of 16 to 53, and the female recipients are 42% in adult in pediatric, and almost 58% in the 58% of the recipients are male patients. And similarly, in adult patients, 64% are male patients. So most of the recipients were male, whereas the donors were female. Approximately 60% of the donors were female. According to the jaundice to encephalopathy time, the categorization of acute liver failure, that is hyperacute liver failure, acute liver failure, and subacute liver failure. Most commonly, they presented with like acute liver failure, and almost 1/3 of the patients had hyperacute liver failure, and approximately 10% of the patients had subacute liver failure, which is also very common in our setting, particularly drug-induced liver disease or autoimmune and indeterminate variety. They will present like subacute liver failure. Coming to the etiology specific, most common etiology we faced are hepatitis A, both in pediatric and adult. In pediatric, hepatitis A is a little bit more compared to the adult patients, followed by hepatitis E. And other etiology
accounts for 15.7%, which includes Wilson's disease, autoimmune, and drug-induced liver injury. And one thing which is specific to our part of the globe is ATT-induced etiology, ATT-induced acute liver failure, which is approximately 10%. And one important thing is indeterminate also accounts almost 22.5% of all the transplants, and similar distribution between both the pediatric and adult patients. Coming to grade of encephalopathy, most of the patients had grade 3 or grade 4 severe encephalopathy, which is 76%. More commonly in pediatric, which is 82%, and in adults, it's 70%. Almost 90% of the patients had a preoperative ICU stay. The need of mechanical ventilation was to the tune of 83%. The pre-LT mechanical ventilation days is approximately 2 days with interquartile range of 1 to 4. Coming to other parameters at the time of admission, that is serum sodium level and ammonia. Ammonia level in pediatric patient is 227 on an average, the median value, and the adult is 312. Total bilirubin level, these are all highly jaundiced patients, 20 bilirubin in pediatric and 25 in adult. PT-INR value is quite high, 4.6 and 4.17. Almost 50% of the patients had SUDS by definition at presentation, and 30% of the patients had shock with vasopressor support. Clinical cerebral edema was present in 20% of the patients, and cerebral edema documented on CT scan was approximately 1/4 of the patients. Coming to the sepsis part is also very common in our setting. That is, most commonly the source is ET secretions and the bowel culture positivity. And these patients, almost 50% of the patients in pediatric and 30% of the patients in adult patients, they had plasma exchange before being considered for liver transplantation. The vasopressor support was almost 30% of the patients. Dialysis and CRRT, predominantly in view of hyperammonemia, is 31% of the patients. Time to transplantation from admission, median time is 48 hours after the first referral for liver transplantation. Most of the patients, they satisfied KCS criteria. Even almost 30% of the patients, they had single criteria satisfaction in pediatric, and 20% of the patients almost they had satisfaction for single criteria in adult patients. And 2, 3, and 4 criteria, most of the patients satisfied either 3 or 4 criteria of King's College criteria. Coming to operative details, that is the graft type. The common graft used was right lobe without MHP, 48%, followed by left lobe, subsequently the left lateral and DDLT. In pediatric patients, the common graft that was used is left lobe graft, which is 41%, followed by left lateral, and equal number of right lobe graft too. In the adult patients, obviously the right lobe graft was more commonly performed in these patients. GRWR average is 1.11 in pediatric and 0.92 in adult patients. The cold ischemia time, warm ischemia time is almost kept minimum, and by balancing the both recipient and donor operations. The blood loss is 710 in adult and 1300 pediatric, and 1350 ml in adult patients. Operative time is shown 680 and 740 minutes. Coming to complications in recipients, grade 1 complication was seen in 5.6% of the patients. Grade 2 complication 41% of the patients, among which the most common complications are sepsis, acute cellular rejection. One of the important things we should highlight in our setting is critical illness neuropathy, which is seen approximately 13% of the patients in pediatric and 4% of the patients in adult patients. And this is because of pre-op mechanical ventilation and ICU stay, and subsequently a delayed awakening in those patients and having critical illness neuropathy. Coming to grade 3A complication that was present in almost 12% of the patients. The type of complications are pleural effusion needing drainage, SSI, liver biopsy required for various reasons, including the acute cellular rejection, early bile leak, or portal vein stenting, which was required in one patient only. And hepatic artery thrombosis is very rare in this cohort, and angioembolization because of some bleed that was also required in one patient, in pediatric patient. Coming to grade 3B complications, that was present almost presented in 11% of the patients, among which tracheostomy in view of critical illness, neuropathy, and prolonged awakening and prolonged period required in ventilation and ICU stay. Those patients may require tracheostomy. Re-exploration for HAT is 1.3% of patients only. ERCP and stenting for biliary anastomotic stricture only in two patients. And re-exploration for bleeding, debridement, and dilatation, evacuation of residual conception product in one patient in pregnancy induced acute liver failure. Grade 4A complications happened in 8.4% of the patients, whereas grade 4B in 7% of the patients. Among these, the most common reason for grade 4A complications are cerebral edema or sepsis. Coming to grade 5 complication, that means those complications leading to death in the recipients happened in 14% of the patients. And a common scenario is sepsis and MODS, multi-organ dysfunction syndrome, and diffuse cerebral edema with or without intracranial hemorrhage, also one of the common cause. Severe acute rejection, and 3 patients are intra-alveolar hemorrhage because of persistent coagulopathy, allograft dysfunction, and biliary anastomotic stricture. Those were the causes for death. Coming to factors predictive of post-transplantation mortality in adult patients. So these are the factors which we analyzed among the survivors and the non-survivors. Among all the factors, as you can see, the parameters which are responsible for or can be attributable for mortality. One is SIRS before being transplanted, and the other factors are positive culture. Sepsis definitely determines the post-LT course. And among the operative factors, cold ischemia time came out to be significant. And post-operative factors, persistent brain edema, which was there in pre-transplantation period, and pulmonary complication. These are the main factors, along with the neurological complications. And these are the factors which contributed to mortality in adult recipients. Coming to pediatric acute liver failure, the factors affecting the mortality. Cerebral edema, persistent edema is one of the factor, along with ammonia level came out to be significant, contributing to mortality. Pre-LT mechanical ventilation more than 24 hours, which is a very important factor, is responsible for, contributory to mortality. Along with SIRS and positive culture, sepsis is one of the constant factor modifying, attributing to mortality in both adult and recipient. Among the post-operative factors, persistent brain edema, AKI, and pulmonary complications, and sepsis. All those obviously contribute to mortality. Coming to overall survival in adult patients, if we look at 1 month survival, it's 76%, and 1 year survival, it's 66%, and 5-year survival is 64%. With a long-term follow-up, 10-year survival, it's approximately 60%. And pediatric transplantation and the survival is quite encouraging, which is 88% 1 month survival. 1 year survival is 75%, and 10-year survival is 70%. Now I will hand over to Dr. Sahil for regarding the literature and the.
Nihar,
Yes.
before you leave, can you go to your other predictors of mortality slide?
Yes.
Yeah, I just wanted to know the benefits of CRRT. Go back. One more slide. So did CRRT help in any way? It's always a question in my mind. PLT CRRT,
Yes, sir.
was it reducing by 13%? Is that correct? What does it mean?
Uh,
Is hazard more?
or
1.108 means it is 10% more. What does it mean?
no, so this since the numbers are 4 and 17 in
Go
the
to the adults.
Hmm.
Go next one. Anyway, another time, just look into it. Two things which we have to resolve is the benefits or
yes,
risks of
benefits of
plasma exchange
CRRT.
and CRRT, whether plasma exchange or CRRT has added
Yes, sir.
or benefited or not, like pulmonary complications.
Plasma exchange has benefited in pediatric patients. Sahil is going to show that literature, and that is one of our
No,
publications.
literature nahi.
That is
data ke basis.
from our data only, literature
Okay.
from our institute only. Plasma exchange has benefited. Regarding adult patients, we have to analyze that thing, whether plasma exchange or CRRT benefits or not.
And you have out of 3 to 60, 20 have not survived. That also the main cause of non-survival is what? Cerebral edema
Sepsis and survival.
and pulmonary complications.
Yes, sir.
Okay, we have to reduce them by our own medical and surgical combined.
Yes.
Vinay, you have comment?
Yes, sir. Yes, sir. So coming to, that's a very good question actually about CRRT, whether it helps or not. Even I was, when I was looking at these slides and I was just trying to make out some sense out of this data that whether CRRT has helped or not. I think we need to divide this into era wise because CRRT is happening more commonly in recent times. Previous patient actually didn't have that opportunity to get the CRRT. My feeling is if we divide this data into era wise, like first 50 and the rest, then actually we will be able to tell whether the CRRT has actually helped or not. This has not happened because this was just analyzed yesterday only, yesterday night actually. And even I was last night also, and this morning I was looking into it, what the numbers are saying and all those things. But I don't think this slide can make this up. So I think once we divide era wise, because personally what I have experienced, patient who had CRRT started before the operation, I think the risk of their cerebral edema post-operative decreases. That is one thing, Rakhi, I will agree with. Okay, that CRRT may be helping in perioperative period in terms of taking care of cerebral edema during that process of having the operation and immediately after the operation, because the liver has to take the time to actually metabolize all the toxins and everything, where CRRT might actually help. So we've been continuing CRRT almost like 24, 48 hours after the operation. And what we have seen is
So
the
it
recovery.
will
is
be
much
good
better.
to collect the data in relation to the lung volume if we have the other data, but not the point here to discuss. We'll hear you and then come back to it after your discussions. So.
Plasma, I'm not sure. I'm not sure because previously our own analysis actually did say that maybe plasma, which has gone into one of the papers, but I think more recently anesthesia guys have analyzed the data as well, and the plasma hasn't helped actually. So there is, I think Gaurav and they have analyzed the data in terms of plasma. Previously, I think one of our publications showed maybe better neurological recovery, but the numbers were very low at that time. More recently, I think anesthesia guys were analyzed and plasma, we're not sure about it.
Sir,
Okay.
can I?
Yeah, Rakhi, please.
Sir, it's an excellent data. And what I would also like you to, sir, if you can take out, because era-wise we had shown that with era we are using more CRRT, and that how survival had shown a certain benefits with respect to usage of extracorporeal therapies. For your data, I would like to know, one is timing of CRRT and intra-op and 24 to 48 hours where you continued versus the group where you did not continue, because cerebral edema and neurological complications were making a difference in your data. So one is that point. The second was with respect to sepsis. So patients who got died of sepsis, how many of them were undergone plex, means plex causing sepsis post-transplant, versus patients who were already septic and then taken up for transplant and did not get plex? So that will also add a lot of value to the existing problems that we face in understanding these patients.
Yeah, I agree. So we need to do it era wise. And then more recently, because both of these things are happening more commonly with the patient, so then we will know exactly what is the impact of this. But CRRT personally, I think is helping.
Yeah, of course.
Yes, so that is the reason we are continuing CRRT post-operative at least for 24 hours.
And people have not
Previously, we were
going
not
for
continuing.
intra-op also to be continued, CRRT. And because cerebral edema is a killer, so we see in and that's how your cohort of viral etiology also makes a lot of difference.
Mhm.
To see hepatitis A are less in your cohort. So the other etiologies are very important.
Also, you should preserve all these. The patient you are taking today, Ankit, his liver volume is 20. This guy was moving around day before in the night, morning was okay, and in the night he goes to grade 4. So in just about 12 hours or so, but his entry liver volume, liver size is 20 centimeters. So I want you, and I've asked Sarthak to go and see in the ICU, in the transplant, how small the liver has become. From 20, has it come down, and what it looks like. And we should preserve all these blood and livers. In just 12 hours, this guy goes from maybe grade 1 to grade 4. And okay, please,
So
Sahil.
just one small
Yeah.
comment is about, I would request microbiology also to that. Whatever the ET and BAL positivity cultures, have they been confirmed? And whether these patients had some radiological appearance of chest X-ray, whether they are leukocytosis, otherwise these positivity cultures should not be, absolutely considered as sepsis. So that needs to be analyzed as well. And sometimes we load them with so many antibiotics, so we have to be careful.
Thank you. Thank you, Dr. Nihal. Good morning, everyone. So I'll be taking the few questions which sir presented, plasma exchange, what are the literature about it and everything. So I'll start with basics. So I'll be talking about acute liver failure. It's a race against the necrosis of the liver. The turning point between acute liver injury and acute liver failure is hepatic encephalopathy, as we all know. And the spectrum can be hyperacute, which is within 7 days. 7 to 21 days is acute, and subacute is more than 21. But it is based on etiology as well. Generally, acetaminophen, paracetamol causes hyperacutes. Viral etiology is acute, which we see in more common, and subacutes like DILI and indeterminate. And in ALF, the main thing also is etiology. In Western part of the world, acetaminophen is most common, so the Western literature does not always apply to the Indian population. In our part of the world, viral etiologies and now DILIs are also very common. So when a patient meets criteria of INR more than 1.5 and encephalopathy, we do a tox screen for paracetamol, viral screen for hepatitis A, B, hepatitis E, and then we have also to be checked for Budd-Chiari autoimmune ceruloplasmin. And we kindly do not label as indeterminate until unless the paracetamol poisoning is negative and comprehensive viral screens are negative, because there can be viruses like varicella, herpes, which can be found positive. And ALFs can present as various complications like neurological complications, infection, as we all talk, pulmonary complications very common, acute kidney injury, hemodynamic instability, and coagulopathy. And there are different prognostic scores like King's College criteria, which is very highly specific, which predicts death well, but it's very low sensitive. It misses the patient who needs a transplant. Other criteria are MELD score, which we are more familiar with because we deal with CLD patient day in and day out, but they can underestimate coagulopathy risks. And dynamic scores like ALF-SG, which includes coma, clinical condition of the patients, are complex calculations. The most important point is the dynamic trends are more important rather than the static score. In paracetamol poisoning, rapid rise in lactate. In other ALFs, rapid rise in INR should be a red flag and should be taken into account. I'll talk about brief about general management, as we all do. Neurologically, head rise to 30-degree, quiet room with minimal stimulation. Metabolically, we prevent hypoglycemia, neuroprotection is done, avoid nephrotoxins, and treat vasoplegia. So I'll talk about questions one by one. This is first managing cerebral edema. The old standard was invasive intracranial monitoring. but recent literature shows risk of invasive intracranial monitoring is higher than benefit. The current standard of therapy is ammonia clearances using hypertonic saline, early CRRT or temperature control. Non-invasive monitoring like ONSDs, optic nerve sheet ultrasounds are more common. So we do not do invasive intracranial monitoring anymore. So hemostasis, as we all know, INR is high in these patients, but do they bleed? But actually, the bleeding risk is not high with high INR because platelets are low, but there is very highly active because of von Willebrand factor compensation. So we do not chase INR, we do not correct INR unless we think there is a risk of active bleeding. There are etiological specific therapies as well in acetaminophen and acetylcysteine. Time dependent and acetylcysteine is important. In optic hepatitis, steroids have been tried, but it should not be given for more than 7 days if there is no response. And in herpes HSVs, acyclovir, mushroom poisoning, penicillin G, and pregnancies, delivery helps. So these are etiological based medical therapies. So now the question is, when hepatocyte necrosis happen, it leads to cytokine storm. And there are various liver assist devices, as we'll talk about therapeutic plasma exchange, CRRTs, and MARS, which can theoretically lead to decrease in this cytokine storm and improvement in multi-organ failures. So we'll talk about therapeutic plasma exchange. The first literature, the biggest literature came from Larson's trial in 2016. We showed high volume plasma exchange in patients with acute liver failure, RCT. We showed benefit 58% benefit rather than 47%. This is the first RCT, bigger RCT. We showed liver support system shows a survival benefit in RCT cohort. But when we look into literature, the plasma exchange is not replacing transplant. If we see the subgroup analysis in this study, patients which are fulfilling the liver transplant criteria and receiving transplant with or without plasma exchange have better survival as compared to patients who do not get a transplant. So we have to see the literature in detail. And they have also shown the patient, this is the second graph which shows the patient who fulfilled the liver transplant criteria but did not get a transplant. The survival with, although plasma exchange is better than standard medical therapy, but much poorer than if they would have got a transplant. So we should aim for transplant, we should aim for therapeutic plasma exchange as a bridge therapy, but not as a sole therapy unless we do not have a transplant option. This is another trial by Dr. Rakhi, another RCT, standard volume plasma exchange improves outcomes in patients with acute liver failure, a randomized controlled trial, 20 patients in each arm, and they have shown the standard volume of plasma exchange shows similar survival to high volume. The plasma exchange significantly decreases pro-inflammatory cytokines, endotoxins, and DAMPs. And again, in these patients, most of the 80% patients are hyperacute liver failures, and 20 patients in each arm, with only 40% patient meeting King's College criteria. And all the patients included in the trial are patients who do not have a transplant option. So coming to the adult evidence, this is the pediatric evidence from our own institute, ILBS. This shows when you see the outline of it, 46% native liver survival as compared to 26% on with plasma exchange, with day 4 clinical impact of lowering INR, lowering bilirubin, and lowering maintaining mean arterial pressure. But is it actually true? When you delve into this same paper, we see this survival benefit is mainly limited to hepatitis A patient. In rest of the indeterminate etiology or other etiologies, the benefit is not shown. So in hepatitis A, the therapeutic plasma exchange has been shown benefit in pediatric population. So this is the paper from King's College Hospital, which shows real world discrepancy in use of plasma exchange. And they have shown there's no difference between PLEX in standard medical therapy in overall survival and transplant-free survival. And the patient who underwent transplant after PLEX, even one session of PLEX, have not shown any improvement or any improvement in hemodynamic parameter or survival. So there's a real world discrepancy on use of therapeutic plasma exchange in ALFs. Definitely, there is a strong evidence in viral etiologies like hepatitis A and Wilson's. There is a weak evidence in acetaminophen and other DLEs. So we need to use plasma exchange carefully based on etiology as well as the clinical condition of the patient. But plasma exchange does not come without its own problems with metabolic alkalosis, sepsis, electrolyte derangement, and hemodynamic instability, which needs to be taken into account when we do plasma exchange for the patients. And the timing is also very important because in early phase of acute liver failure, there will be SIRS, but in later phase, recovery pro-regenerate macrophage will be there. So timing of the plasma exchange is also very important. The other question which was raised is generally in recent literature is renal replacement therapy, the CRRTs. So this is the use of CRRT beyond kidney. It shows to have better ammonia clearances, better hemodynamic instability, and preserve cerebral perfusion. So this is the evidence. This is systemic review or meta-analysis published which shows in adult population they have compared 305 patients of CRRT and 1100 patients of standard care, and this is observational data. Although the patients in CRRT group were sicker and higher encephalopathy, but still they showed benefit. So they showed 17% reduction in mortality and 35% decrease in reduction of transplant. After this, because of this literature, American College of Gastroenterologists and critical care guidelines have now recommended CRRTs in first-line therapy of hyperammonemia in ALFs. But we need to avoid this clinician drop. This is the line of artificial clearance of urea and creatinine, and this should be the true improvement. So we need to take into account that CRRT is being used. So this dynamic parameter, ammonia and lactate use, is not always indicator of liver recovery. So bilirubin, factor 5, and INRs needs to be taken into account. Trends in in bilirubin and factor 5 reflect true hepatic synthetic function and to be assessed on the timely regular fashions. This is a small window of opportunity. This is a small article from in JHEP in 2025. They have shown early initiation within 2 days have shown survival benefit in CRRT, but not after 4 days. So there is a very small window of opportunity which we have shown. Coming to liver transplant remains standard of care as of now for acute liver failures and its ultimate safety net. The survival has improved with the time as high as 70%. As you can see in first graph, if we delay transplant and if the transplant option is available, with each day delay in transplant, the survival benefit decreases. We have published from our own department. This is the paper published 2019, living donor liver transplant for acute liver failure, and this is a recent published in pediatric liver transplant. Which shows excellent survival outcome with liver transplant. In the second paper, although we have mentioned we saw better neurological recovery with plasma exchange, but we are not sure yet now. So the path forward is what is happening in the future in estimate poisoning. These are bedside tests. The card-sick tests can be done we don't have to wait for labs. All King's College criteria MELD are all static tests. This is 13 carbon methacin breath test is shown to be real-time metabolic function, but it has not been validated in all the cohorts. And then this ALF study group prognostic index, which is a dynamic score which can predict 21-day survival. So immune response can be both friend and foe. Immunomodulation can be one of the things which can change the game for acute liver failures. Then again, it's a race against regeneration. If the regeneration is better, then the liver survives. So there's therapies which can actively stimulate regeneration, like WNT agonists, which are being studied recently. And then again, apoptosis, there are therapies blocking specific cell death apoptosis which are being studied. The literature is yet to come. And then last in this extracorporeal liver support like MARS,
There are mixed results. There is a large meta-analysis for France, which showed there is no survival benefit in Mars, but there is still literature in which studies which have shown benefit with Mars. Stem cell derived hepatocytes and bioartificial devices are yet to be analyzed, and results are yet to fully come. So the future can be bedside testing in ALFs. Then it can be pharmacotherapy, WNT agonist, necrosis blockage, and until then, we have all these therapies. Transplant remains mainstay of treatment. We have to diagnose and offer transplant. If there is no transplant, then definitely medical therapies, CRRT and plasma exchange needs to be continued. In ALF specifically, time is hepatocyte. With every losing minute, we lose hepatocytes. We have to identify early, we have to treat aggressively, and we have to bridge to life, bridge to transplant. I'll call Dr. Nilesh for technical details in ALFs.
So good morning, everybody. Because of time constraint, I will try to summarize what are the surgical challenges in ALF. Basically, in ILBS, we see more sicker patients as other centers in the India, also in the worldwide. So to perform this operation at odd time, especially most of the ALF happens in the midnight, you need an expert team which has lots of experience, especially to tackle the complex anatomies and to perform operation quick but meticulously. And also it has, because the surgery, the margin of error is very small. The pre-op optimization, what we do in routine in ILBS, we usually ship the donor, we start the donor, and we open the donor and we look the quality of the liver. Meanwhile, we ship the recipient on the OT table. Sometimes while shifting, after putting the patient on the table, the ventilatory support, inotropic support increases. So we have to coordinate with the donor team. And sometimes very sick patients who have a toxic liver syndrome, especially young guys, sometimes we have to do a two-stage procedure. It is common in DDLT scenario, even the reports from the worldwide and even from recently from the India and Hyderabad. Even the LDLT has been performed in two-stage procedure. In sick patient, you do a rapid explant, you do it with temporary portocable shunt. Observe the patient on the OT table. You try to monitor the inotops, hemodynamics. The patient improves, the cytokine storm, that is SIRS, lessens. Then you start the donor surgery and you complete the procedure in two-stage procedure. So we have to keep a watch, especially the senior member from the team. We have to coordinate with the donor team and the recipient team. As previously discussed, the most important point is the continuation of the intra-op CRRT. You have to take into account the risks and benefits. As especially in sick patients with toxic liver syndrome, which are in grade 3-4 HE, the pre-op CT showing cerebral edema, it is better to continue the intra-op CRRT. But which are the stable patients, because intra-op CRRT has its own limitations, that is, especially in childs, it leads to hypothermia, which can worsen the coagulopathy. Intra-op CRRT can increase the bleeding complication. The most important is the intracranial bleed. Sometimes the tube king malfunction, it can thrombocytopenia, hemolysis, even the prolonged, because of the prolonged CRRT pre-op, intra-op, it can lead to even hypophosphatemia, which can worsen the new liver regeneration. So we have to balance the risk and benefits to continue the intra-op CRRT. And the surgeon has to be vigilant whenever the patient has developed hypothermia and the coagulopathy worsened. You have to see the surgical field. You always put a good communication with your anesthesia colleagues. We have time constraint. It is not like elective operation. You do slowly, but because patient is rapidly deteriorating, you have to be quick, but still you have to meticulous to perform this operation. Because of this SIRS, usually they have third spacing, the edematous tissues and the inflamed tissues. So to manipulation of the tissue should be very meticulous. Next, the important point is the working space constraint. Especially we see the young male donors, they have narrow costal arch. We have to plan the incision. Usually we perform the operation with reverse L incision, but sometimes we have abdominal wall edema, distended bowel loops. So we have to do a classical Mercedes Benz incision to have a proper exposure. Sometimes because of the lactulose effect, the large, especially the transverse colon has hugely distended the edematous mesentery. So to have a better exposure of the hilum and the liver, we bring the transverse colon out of the incision and cover with the warm saline mops. So have a better exposure. That's why we repeatedly request to both adult and pediatric hepatology colleagues not to give a lactulose in the preoperative optimization. So next part is you have to perform the native liver explant with quick, and we have to do a caval preservation. Usually do a high hilar dissection. That is because in LDLT, the inflows and outflows, the length of the arteries and the portal lamens is short. To have adequate length on the recipient side, we do a high hilar dissection. That means we dissect the arteries as possible in the hilum beyond the bifurcation of the left and the right hepatic artery. Well, because the tissues are inflamed and edematous, usually they have preoperative on the prolonged, they have multiple on CRRT, plasmapheresis. Chances of arterial dissection very high. You have to handle the, should not negate the arteries. You always, because we see always the two large lymphatics run along the artery. We manipulate the arteries with that lymphatics, and also should not put the ligature or clips too tight on the arteries. That can fracture the intima and can lead to dissection. Because if the arterial dissection happens, the surgery is happening odd time, it will be the nightmare for the surgeon to manage that arterial dissection. So we divide the bile duct as possible. Sometimes you get multiple ducts on the donor side. So we divide the bile duct above the portal bifurcation. We lengthen the portal main proximally, and we take the right and the left. I will show in the video. We usually take the right and left portal vein separately, because sometimes usually the distance between the portal vein and the IVC is 1 to 2 centimeter. But because of the SIRS tissue edema, that distance increases, and while making a shunt, sometimes the portal vein doesn't reach to the cava. So we have to have adequate length to form a good shunt. So you do your early shunt to prevent the toxic liver syndrome, and then we mobilize the liver. After opening the abdomen, we do not manipulate the liver much, unless after hilar dissection and after formation of the shunt only we mobilize the liver. First, we mobilize the caudate from the cava and the rest of the liver from the diaphragmatic attachments. Especially mobilizing the caudate, sometimes though they are normal livers, sometimes they have complete caudate wrap around the IVC because tissues are inflamed, the planes are not good. Chances of caval injury are very high. So you try to perform it meticulously, because any hemodynamic instability will leads to worsening of the brain damage. Next part is the meticulous benching. That is very important, especially usually in the small kids up to 20 kg, the left lateral graft is sufficient, and more that we take a left lobe graft, and adults we take a right lobe graft. Especially in the right lobe grafts, we usually to have the functionality of all the graft to improve, we drain the anterior sector properly. We have already published, that is, we recreate the new MHV with a PTFE, and we reconnect the PTFE to the RHV to have a wide opening outflow. In left hemigraph grafts on the pre-op CT, sometimes we get a MHV, LHV, the separate opening. You have to have wide outflow to have at least 4 to 6 centimeters. Sometimes you do a septoplasty, or you do a unification combined venoplasty. Sometimes you widen the opening. We get a superficial hepatic vein on the left side grafts of phrenic veins. We extend the opening over the phrenic veins of the superficial veins. We keep cold ischemia short and warm ischemia, as previously discussed. The prolonged cold ischemia time is a predictor of the post-transplant death. So always coordinate with the donor team to have a minimum cold ischemia time and the warm ischemia time. Especially we try to avoid because this is odd time surgery, emergency or complex operation. We try to avoid the complex anatomy in initial part. But as expertise increase, even you can tackle the complex anatomy, especially the multiple inferior veins, because putting a multiple clamps on the cava is equivalent to the cross clamp. So we try to take a simple anatomy to have quick, safe operation. Usually the reperfusion happens with sequential anastomosis. We do plus the outflow reconstruction to have wide outflow. It depends on the it depends upon we have to different plans for the different patients, especially patients who have toxic liver syndrome usually have distended bowel loops, lots of tissue edema. So we first reconstruct the outflow, and after that we dismantle the temporary portacable shunt. Otherwise, sometimes the graft has, especially the right lobe graft, it has multiple inferiors. We need a side clamp on the cable. So and the patient, there is no much tissue edema, no distended bowel loops. We dismantle the TPCS initially only before reconstruction of the outflow. So you have to individualize your plan according to the patient. And we try to avoid the cross-clumping of any cross-clumping lead to hemodynamic instability. We try to avoid that. All inferior hepatic veins we reconstruct, especially which are more than half a centimeter in size. Even the proper implantation of the inferior hepatic vein gives the proper position of the graft in the abdominal cavity. And portovein, after that, portovein reperfusion is performed. After reperfusion, especially in the large grafts, we have tissue edema, we have prior toxic liver syndrome, they have to prone for the reperfusion syndrome. So during reperfusion, at least made the head position, you try to make a neutral or slightly head low to avoid the cerebral hypoperfusion. After that, we perform the hepatic artery anastomosis, which is usually done end-to-end with the interrupted anastomosis with eversion technique. And after that, we do a Doppler to confirmation of inflow and outflow. And after that, we do a bile duct. Bile duct, we try to prefer to duct-to-duct anastomosis because in this means patient doing HJ is not a straightforward because the edematous tissue to making a window in the colon and to make it attaching edematous bowel to the bile duct, chances of bile leak are very high. That's why we do divide the bile duct always above the portal vein bifurcation to have multiple openings. Even the multiple bile ducts come on the graft side, we can do a multibiliary anastomosis. It is a basic all vascular anastomosis. We have tension-free anastomosis. It should be anatomically correct orientation. Try to avoid any kinks, redundancy, or torsion. We should have widely patent lumen. Should not put all the knots very tight to prevent the narrowing of the opening. Sometimes there are two portal veins on the donor side. We have to put a venous patch between the two portal veins, and in especially portal vein, we try to put a growth factor almost 1 to 1.5 times the diameter of the donor portal vein to expand the portal vein and to avoid the postoperative narrowing. The suture line should be hemostatic and it should be carefully taken. Usually their tissues are inflamed and edematous to avoid intimal injuries, which can lead to post-transplant thrombosis and thrombotic events. But during the anastomosis, always tell your nursing colleagues to have regular flushing the anastomotic site to remove any clots. And you should avoid overcorrection of the coagulopathy. Always do a tech-based correction and also to a surgical field to do a correction of coagulopathy to avoid thrombotic events. We arterial anastomosis and biliary anastomosis, we follow the standard techniques which has been published, that the arterial anastomosis do a clockwise suturing technique. We start from the one end and we usually put intima to intima approximation and try to always take a needle bite from the inside, avoid with meticulously avoid intimal injuries, and should not tie the too tight to avoid the narrowing of the arterial lumen. Biliary anastomosis also is done with all not outside technique with mucosa approximation with a watertight closure. Most important part is the surgical hemostasis, because especially this odd time surgery, the all team is tired. So after biliary anastomosis, we try to take a break, freshen up 10 minutes, and after that with a cool mind, we do a surgical hemostasis. Some of the important areas we always look, that is a retractable area where the bleed from the small veins can be disastrous, especially the adrenals, phrenic veins, and the most important, the drain sites. Next important point, the graft fixation, especially the left-sided grafts we implant in the midline. So we have to fix the grafts to avoid the torsion of the outflow. And the abdomen closure, I told previously, because sometimes the bowel edema is that much, we can't close the abdomen, which can lead to a compartment syndrome with other extrahepatic organ dysfunction like kidney and lungs. So sometimes we have to do a Bogota closure to have a safe operation. I remember one child which has a huge abdominal distension. We're not able to close the abdomen. We have put the Bogota up. That child underwent almost 5 to 6 times re-exploration post-transplant. That's why we request our colleagues to try to avoid the lactulose in pre-transplant setting. because obviously that increases the financial burden and utilization of the hospital resources also. So prevention is always better than the cure. Most important, the shifting the patient, it is not just the transferring the responsibility to your anesthesia colleagues. The seniors, surgical team member always go with the patient while shifting the patient from the OR to the IC. There should be a detailed handovers. There should not be any communication gaps. While shifting, you should look after the portable ventilators, try to avoid hypercapnia, maintain the head and elevation to avoid sudden mishaps. Adequate sedation, analgesia, muscle paralysis to avoid the bucking and sudden coughing of the patient. Care of the all vascular access, especially vasopressor infusion to avoid any cardiac instability, and especially for surgeons to look the drains, they should not get caught sometimes and get accidentally removed while shifting. And decision to continue CRRT, it depends on the individualized case to case basis, especially patients who are severely sick, especially in the
Sorry,
marginal
Nilesh, to
grafts
interrupt
with
you.
low
It's a
GRWR.
beautiful thing. Are you summarizing or?
Yeah, I
more
just
slides?
finished, sir. Next
You have
video.
finished?
Yeah.
If there is, Vinay, there any other presentation or you are going to speak or? Yeah, because they want to show something very important about the decision for our layout for the landscaping for that. But sorry, very sorry. I enjoyed every part, Nilesh. Very
Thank you.
well done. And Vinay to speak and wait around. Please wait. Very well done, Nilesh. I must also, while you are climbing, say that all these acute liver failures required the operations team to get consent and logistics. And fortunately, Dr. Rastogi is here, so we'll give him also in the operations team, the transplant coordinator and everyone, a big thank you.
Okay.
Yes.
So, morning, everyone. Very nice presentations from Nilesh, Nihar, and Sahil. Well done, guys. Sahil, the slides were very good, actually. Really liked it. So, what I'm going to do is I'm just going to touch on this contentious issue of how to select patient for liver transplantation in acute liver failure. And I think this is the crux, actually, which makes most of the difference what happens to this patient. So this is, you've seen this slide before. So we are now almost touching 1,400 transplant, and we've done more than 200 pediatric transplants as well. And these are the outcome. And when we look at the outcome, the outcome was shown by Nihar as well. So this is now ALF is 133. So the crux here is this is the perioperative mortality which is making a difference. And this is just because how sick the patient were before they were taken up for transplant, and can we improve on this front in order to have better outcome, because this is a huge effort. Transplanting ALFs and ACLF requires a lot of effort, requires a lot of resources, and also a huge financial burden for the hospital and for the patients as well, because patients are in package, so you don't really realize how much actually expenses can escalate in this type of patients. Okay, so how we can do it? So when we look at our mortality, so sepsis and multi-organ dysfunction, diffuse cerebral edema with brainstem death, and diffuse cerebral edema with intracranial hemorrhage and alveolar hemorrhage as well, intrapulmonary hemorrhage. So these have been the major killers after the operation. So how we can improve on this? This is about, most of this is coming before the operation. These are not the things which have happened during the operation or after the operation, after the new liver has come in. These are factors which have been playing before the operation, and can we get better on this? And when we look at the multivariable analysis, it is persistence of cerebral edema and SIRS and positive cultures, which are the one which are playing part in terms of perioperative mortality as well. And why we are having this problem? The problem is because we are following a King's College criteria in selecting patients for liver transplantation. This is not good for us. This is not meant for our patient. This was meant for patients in UK or Western patient. This was never meant for Indian patient. And we need to realize this strongly in order to improve this outcome. So KCC was derived for West. Presentation and etiology is very different in India. Indian patients have a very different presentation for ALF. KCC can detect patient with poor prognosis, but it's not accurate in predicting that everyone who doesn't fulfill the criteria will survive. So it can just tell you that patient who fulfill the criteria, they got a very high probability of dying. But the patient who does not fulfill the criteria, it doesn't guarantee that those patients will survive with native liver. And that's the biggest actually problem with KCC. And we need to realize this. So even in the best centers, even who doesn't satisfy criteria, 50 to 60% die if they have SARS, sepsis, and cerebral edema. So there is a high specificity here, but a very low sensitivity in terms of selecting patient for transplantation. And what are the problems with KCC? It is about basically there are four most important factors which play part in terms of what the outcome of patient is going to be. It is severity of cerebral edema, SARS, sepsis, other organ dysfunction, and hemodynamic instability. And these are all which are not part of KCC as a criteria for selecting patient for transplantation. So one has to realize this. This is the most important thing, because factors which are actually killing patient are not part of the criteria for which you're selecting a patient for a treatment modality. That's what the difference makes in. So when you look at acute liver failure, when it is hepatitis, it is about hepatocyte injury and hepatocyte repair. So that's a balance there. When basically injury is more than regeneration, then it is failure. And when you have a necrotic liver, it actually excites in terms of SARS, sepsis, cerebral edema, and multi-organ dysfunction and failure. But that's where the bad news comes in terms of what will happen to the patient later on. And when you look at the mortality driving factor, this is cerebral edema and SARS sepsis, which are actually entangled together. They actually enhance one another. Once you have SARS sepsis, there is high risk of developing cerebral edema. And if you have cerebral edema, then there is a high risk of developing SARS and sepsis as well. And what are the factors which precipitate this? This is again, it can depend on etiology. If you have an infective etiology, high necrotic liver, it will have cytokine storm. Then you have gut failure leading to translocation. Then you have respiratory problems, mechanical ventilation, infection, trolley associated with plasmapheresis and CRRT as well. Then again, cerebral edema will lead to SARS and sepsis as well, fluid overload and uremia. So all this actually contributes. So these are some of the things why I put in this slide here is there are few of these things which we do in ICU, which can actually precipitate SARS and cerebral edema and actually be a counterproductive for us. So we need to be careful when we manage this patient in ICU that we are not harming patient rather than doing good. We're not harming patient by doing more things which are not required for the patient. And that's, I think, very good, very big message we need to keep in mind when we manage this patient in ICU as well. So again, this is again just to put that thing, that criteria for liver transplantation are based on hepatic encephalopathy, bilirubin, INR, ammonia, and lactate, whereas the outcome is dependent on cerebral edema, SARS, sepsis, hemodynamic instability, and hepatic organ dysfunction. So this is our etiology. This is very different from West. West doesn't get this etiology. 36% is hepatitis A, and then undetermined is 44%. Most of this is basically we don't have tests to know why this has happened. That's why it is undetermined. So this doesn't happen in West. And this etiology is especially undetermined, behaves very differently than what patients are seen in West. So we need to be very clear about this. Then we see a lot of ATTs as well there, which have again worse prognosis as well. Then there is a common belief that hyperacute presentation is associated with good prognosis. Hyperacute is basically within 7 days. Jaundice to encephalopathy period is less than 7 days. But when you look at, and then when you combine with etiology, again, the mortality in this group of patients remains high, in spite of having hepatitis E and hepatitis A. So hyperacute doesn't always mean that they will survive with native liver. There is a group of patients who will still do bad and they need to be selected for patient for transplantation as well. So this is again the data from the literature. And you can see if you have grade 3-4 cerebral edema, irrespective of other factors, the mortality actually goes beyond 70%. So that's one triggering factor when you have a patient in ICU, irrespective of bilirubin, INR, and other factors who have cerebral edema, there is a high risk that they may not survive without transplantation. And these are patients who need to be assessed very quickly for transplantation as well. Again, this is our own data. And you see the criteria, because again, I'm coming back to criteria again and again. And you see, even patients who are not satisfying criteria, 1 in 4 die when they are not satisfying any of the King's College criteria. Then if they satisfy one, it is 44%, 2, 57%, 3, 62%. And if you have a single criteria INR more than 6.5, the mortality is beyond 80% as well. So this are important thing. You can't beat these numbers. These numbers are very important to remember in order to select patient for transplantation as well. And again, as I emphasize, hyperacute doesn't mean that everybody is going to survive. So this is just to summarize that how to select patient. So you need to look at severity of cerebral edema, sepsis, organ dysfunction, hemodynamic instability, not just the criterias. And this we have talked about in the whole ground round. So I'm not going to go again through this. And these are 2 important papers which we have published. I hope everybody should read this, because don't just go with the abstract or the title of the paper. Just read everything in this paper. This is a very important publication, and that will tell you exactly what is happening to Indian patients in acute liver failure. So there's good. Good is when your transplant patient survives, it's very good. Bad is you delay the transplant unnecessarily, and then you have to have put a lot of resources into it in order to get an outcome. And the ugly is the patient has been delayed too much that it becomes a futile transplantation as well. So thank you very much. Thanks a lot.
Very nice, Vinay, and I think we all are very happy and proud, and I wish we could continue this for longer. But I must say that Ved, why don't you load your slides meanwhile you have? While I could see that you can, in 14 hours, you are able to prepare the patient and take up to the transplant. I think this is amongst the fastest anywhere in the world. So the still delay is not intentional. It could be logistic or the family, but you have done well. The survivals are very good. I think we should have a combined ALF medical and surgical both, so that we can look into the pathology and look. It's a huge data and very good success rates. A big round of applause. They are showing you, I would like at least the faculty and residents who can. This is what your residential complex is going to be, and it is what you might be waiting to get allotted. And our general manager engineering